So we're going to move on with our next speaker, Dr. Isaac Bogoch. He's an infectious disease specialist, and he's coming to talk to us not about COVID, about other infectious disease things. So Dr. Bogoch, if you're, oh, there you are. Come on up. Thank you very much.
All right. Oh, wow. Morning, good afternoon. Great to be here. Thanks for having me. Thanks for the invitation. I'm Isaac Bogoch. I'm one of the infectious disease docs based at the Toronto General Hospital. We're going to talk about infectious diseases in the emergency department, some practical tips, some non-COVID related tips. The whole goal is to not talk about COVID. Hopefully we can do that. All right. A couple of disclosures. First, I consulted to the NHL Players Association and to a company called Blue Dot. They track emerging infectious diseases. We're not going to talk about anything related to that today. Okay, we're not going to talk about COVID. This is my favorite photo of the pandemic. I know we've all felt like this multiple times. Hopefully the worst is behind us. Hopefully we can move forward, but I don't know. There's something about this. This photo's amazing. This slide's supposed to remind me to say two things. Number one, we're really going to talk about some bread and butter ID issues that are relevant to the emergency department and things that have actually come through the literature over the last couple of years that we might not have seen because we've been so overwhelmed with other issues. It's also to remind me to thank David Carr. I think he spoke here yesterday. I usually speak with infectious disease docs, with general internists. I don't speak with emerge docs all that often, and I gave a talk to some emerge docs, and David said, hey, good talk. Your slides were junk. You have way too much, you have way too many words on your slides, not enough pictures, so I made this more photo heavy. The ID folks and the internists like words. Looks like emerge docs like fewer words. I'm happy with that. Let's jump right in. Everyone is seeing patients with suspected bloodstream infection. Everyone's seeing patients with sepsis or pre-sepsis syndromes. What happens, what do you do for an antibiotic standpoint in the emergency department for patients presenting with a potential bloodstream infection? This came out recently, and this is it's in the ID literature, not in the emerge literature. I thought it's reasonable to chat about here. It's a big multi-centered observational study. Over 3,000 people enrolled in this study, and they looked at a very simple question. Do you give your beta-lactam first, like your cefadroxil, or do you give your vancomycin first? They found that if you prioritize the administration of the beta-lactam, like the cefadroxil, before the vancomycin, it might actually reduce early mortality. Very cool, very simple, easy tip, practice changing. Give your cefadroxil before vancomycin. Simple as that. I don't think this story is over yet. We'll probably see some prospective studies that will iron this out, but for now, based on the data we have to date, I think it's a very simple thing that we can do, and it might actually help save lives. Let's jump into pyelonephritis. We see this all the time in the emergency department. Imagine a 65-year-old woman who presents with fever, left flank pain, the urinalysis has lukes, blood pressure's okay, heart rate's 90, urine and blood cultures are sent and they're cooking. And you know, there is such heterogeneity in practice over a case like this. And I'm not going to poll anybody, but this is what I did poll people before putting this slide together. These were the recommendations. These were the recommendations from people who are working in the emergency department. And then there was a few others, but these were the more common ones. And again, there's guidance, there's guidelines, but there's a very strong very diverse practice around simple cases like this, and that's okay. But the key thing to really think about is disposition, right? Is this person coming in, or are they going home? The duration of therapy, is it a longer duration or a shorter duration? Sometimes we use football analogies like 1 touchdown or 2 touchdowns, so 7 or 14 days of antibiotics. And the drug, are we using an IV drug or a PO drug? Let's delve into this a little bit. Disposition, most people can go home. The vast majority of people can go home. Obviously, if someone can't take their medication, has a drug-resistant organism, is septic, et cetera, yeah, they're coming in. But the vast majority of people can go home. Drugs. There is a massive pendulum swing towards using pills instead of IV. And you will see this time and time again. It's mostly in the ID literature, but it's making its way into the other specialties. PO antibiotics are just as good, sometimes better, than IV antibiotics. So pills, 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 rather than IV, IV, IV. You reduce morbidity associated with IV, and you can provide the same high quality of care with PO antibiotics as you can with IV. And lastly, duration. You're going to hear this time and time again. Shorter is better, shorter is better, shorter is better, or at least shorter is non-inferior. Anyone remember this movie from 100 years ago, Twins, with Arnold Schwarzenegger? I mean, I'm dating myself. But yeah, so those are the things. And again, there's data to back this up. And the data isn't even new. It goes back a decade, and there's just more and more data now. 7 days of antibiotics is non-inferior for the treatment of pyelonephritis in both men and women. Pills, they use Cipro in some of these cases, but other PO medications are just as good as IV, sometimes better because you avoid the morbidity associated with IV. An important slide. There's growing incidence, and this is a huge problem, of antibiotic-resistant organisms. This is downtown Toronto data. This data will not be the same for where anyone practices. The y-axis might be a little bit different, but the graph is going to be the same. Over time, we are seeing more and more antibiotic-resistant organisms. It's really important to know what's circulating in your neighborhood, because that's going to determine what you're going to use. But even with this, there are still good PO options. Talk to your friendly neighborhood infectious disease doc. We're happy to walk through this with you to choose a smart oral option to send your patient home. This is the game show Facts Don't Matter. The host says, I'm sorry, Jeannie, your answer was correct, but Kevin shouted his incorrect answer over yours, so he gets the points. We saw a lot of that over the last couple of years as well during the pandemic. Okay, segue, cellulitis. Bread and butter case, right? 68-year-old person with cellulitis, 24 hours of leg pain, some erythema, some warmth, mild edema, and there's no risk factors here for any funny organisms. No bites, no water exposures, no travel. This is your bread and butter cellulitis. Okay, what's new in the world of cellulitis, you might ask? Not much, but maybe something. Remember, cellulitis we think about in terms of purulent or non-purulent. If it's non-purulent, it's almost always going to be a strep. If it's purulent, it's almost always going to be a staph. And staph, we think about MSSA or MRSA. You can't tell by looking at it. And the treatment's pretty straightforward, right? For strep, you can use a penicillin or cephalexin, 500 QID. For staph, you're not going to know if it's MSSA or MRSA. So sometimes we just treat for MRSA until proven otherwise, and you can use your doxycyclines or your Septras twice daily. And you treat for 5 to 7 days. If there's pus there, you try to remove your pus. Pretty straightforward, pretty straightforward. But look at that, QID drugs in 2022. We're still using QID drugs. Can we do better? Is there a better drug for example, strep or MSSA? And the answer is, of course there is. There's a wonderful drug, cheap, widely available here in Canada, everywhere, at every pharmacy, cefadroxil. Cefadroxil, your friendly ID doc is giving out cefadroxil like Halloween candy. More and more people are using it. You can use a gram PO daily. You can use 500 milligrams PO twice daily. Simple, practice-changing advice. Instead of using a 4-time-a-day drug, you will get much better adherence with a once-a-day drug or a twice-a-day regimen of this. And it has virtually the same coverage as your cephalexin. Cefadroxil, if you work in Canada, it's here. We use it all the time. It's cheap, it's available, it works. Okay, this is the last COVID slide. This was a sign somewhere it says, please wait patiently for the failure of the system. You can see I'm a little bit jaded over the last couple of years. Okay, uncomplicated UTIs. 72-year-old female sent to the emergency department. She's got urinary frequency, dysuria, no fever, classic lower urinary tract infection, classic uncomplicated urinary tract infection. But she's sent to the emergency department because there's no oral options. I don't know what to do. I can't find an oral option for her. She truly has symptoms. She needs treatment. I just can't treat her as an outpatient. Sorry, go to the emerge. This is not the susceptibility profile, but it would look something like this, okay? You'll look at that list, and it's terrible, right? There's no oral options, and you've got like IV susceptibility to like gentamicin or colistin or tigecycline. Like, it's terrible. These are all, not only there aren't any oral options, there's just bad IV options as well. Okay, we're seeing this sadly with increasing frequency. And the person needs treatment, right? She's got a UTI. It's symptomatic. It's the real deal. It's not, life-threatening, but it still needs to be treated. Anyways, this is a reminder that you do have pills, or you have drugs, at your disposal that will work. Fosfomycin. Some people are using this. Some people might not know about this. It's a really good medication. It's a single dose. It comes in a little package. You mix it in with water. It's 3 grams in a package. You mix it up. It tastes like, anyone see this? It tastes like an orange. It's like an orange drink, like that McDonald's orange drink from 100 years ago. Anyways, it's actually pretty active against many antibiotic-resistant gram-negative bacteria. You can still get susceptibilities for this, but in general, this is still a very effective agent, and you're seeing people use it more and more. It's not perfect, but it works really well much of the time. So something that you have in your back pocket, fosfomycin. Let's move on to pneumonia. Classic case of pneumonia. What's new in pneumonia? Not a lot's new in pneumonia, but again, things we might have missed over the last couple of years while we were bogged down with COVID. So 64-year-old gentleman comes in, cough and shortness of breath, febrile at 38. He's satting 94% on room air, okay? Blood pressure and heart rate are okay. He's not in overt respiratory distress. He's sick, but he's not in terrible respiratory distress. You've got a negative flu and COVID rapid test, and he's in your emergency. You could probably send this guy home. Okay, you've seen this a million times. Everyone has their own outpatient community-acquired pneumonia therapy, right? You might give a respiratory fluoroquinolone. You might give a moxiclav. Some people might be giving azithromycin, whatever. You've got your plan. You're going to treat for 5 days or 7 days. Some are treating for 5, some are giving 7 days. There's still some heterogeneity in practice, but you've got your pill, you got your duration, you got your disposition. Amazing. Anything new in this field? Yes, believe it or not, there is. People have looked at actually stopping the antibiotics early. Can you have your patient stop the antibiotics early? We always say, oh, finish your pills, finish your pills. It's so important that you take all the pills. Don't cut this short. You actually can. And this is a really neat study, multi-centered study, looking at people stopping their antibiotics after 3 days if they were showing signs of improvement. And they were given beta-lactam antibiotics, but nevertheless, they stopped them at 3 days if they were showing signs of improvement. What were the signs of improvement? They defervesced, their heart rate was under 100, respiratory rate under 24, SATs greater than 90, blood pressure is reasonable. Like, this is the kind of person that you're discharging from the emergency department. And it's pretty impressive because what they found is this strategy of stopping antibiotics after 3 days was non-inferior to 8 days of therapy. And I like their conclusions. Our findings support the substantial reduction in consumption of antibiotics. That's a huge deal. That's a huge deal. Why is that a huge deal? What does this mean at a global level? Antimicrobial resistance is probably one of the biggest public health threats of our time. It's up there with climate change. It is a huge issue with immense morbidity, immense mortality, and it's only getting worse. We are all antibiotic stewards, not just your IPAC or your stewardship or your ID folks. We are all antibiotic stewards. This is being studied. This came out, a couple of weeks ago in The Lancet. They looked at the global burden of antimicrobial resistance. They used data from 2019. Okay, it's getting worse, and it's getting worse everywhere, and it's getting worse faster, and there's not enough being done to curb it, and it's landing on our doorsteps, in our emergency departments. It's hurting patients, and it's killing patients, and it's killing about 1.3 million people per year with massive morbidity. I'll say it again. We are all antibiotic stewards. We can all treat appropriately. You will hear this time and time again. Not everyone needs antibiotics. People can have shorter courses of antibiotics. We can use oral pills, oral antibiotics instead. So the take-home points from this. Let's give cefadroxil before vancomycin for potential bloodstream infections. Shorter courses of antibiotics are just as effective as longer courses, and sometimes, not always, but sometimes you can stop your antibiotics early. Oral antibiotics are just as effective in most cases as IV antibiotics, and fosfomycin and cefadroxil are underused drugs, but they're very